Good morning everyone, myself Dr. Sunil Ninama. I am Associate Professor in Cardiac Anesthesia in Mehta Hospital. Today we are going to discuss on the topic for the cardiopulmonary resuscitation. What do we mean by the cardiopulmonary resuscitation? All peoples they said about the CPR, the term used CPR. What do you mean by CPR? C stands for cardio for heart, P for the pulmonary for the lungs, and R for the resuscitation for the recover. The definition of CPR is that the cardiopulmonary resuscitation is a technique of basic life support for the purpose of oxygenation to the heart, lungs and brain until and unless the appropriate medical treatment can come and restores the normal cardiopulmonary functions. While the other definition says that cardiopulmonary resuscitation consists of use of the chest compressions and artificial ventilation to maintain the circulatory flow and oxygenation during the cardiac arrest. There is some history of the cardiopulmonary resuscitation. In the previous days, that is in the year of 90s, they are using the Sylvester methods and their chest compression given on the back of the chest. Previously, there history that is by Jude and Knickerbocker along with the Williams. They are they are the pioneers of discovering the method of external chest compression, while the Dr. Suffer wrote the book on the ABC for the resuscitations. This is the chain of survival. In this, there is an immediate recognition of the cardiac arrest occurred and when activation of the emergency response systems, and followed by there is application of effective CPR, and then followed by there is early defibrillation if applicable, followed by advanced cardiac life support, and then there is the initiation of post resuscitation care. The purpose of giving CPR is to restore the cardiopulmonary functioning and prevent the irreversible brain damage from the hypoxia. Is the 2020 guidelines for the cardiopulmonary resuscitation and emergency cardiovascular care. There is two guidelines. There is in-hospital cardiac arrest and out-hospital cardiac arrest. In in-hospital cardiac arrest, there is an early recognition and prevention, and followed by there is activation of emergency response like code blue team or whatever team in your hospitals, followed by there is high quality CPR, followed by defibrillation, then post cardiac arrest care, and then followed by recovery. While in case of out hospital cardiac arrest, there is first thing is the activation of emergency response, and then you have to give the high quality CPR, followed by defibrillation, then advanced cardiac resuscitations, followed by post cardiac arrest care, and then recovery. The indication for giving CPR is to the cardiac arrest. Maybe there is a VTVF, pulseless activity, or asystole, whatever, and then there is a respiratory arrest, drowning, foreign bodies in the drown. Because of that, patient develop hypoxia and then arrested. Smoke inhalation, drug overdoses, suffocation, accidental injury, and coma. The primary indication for CPR is there is a cardiac arrest or respiratory arrest or combination of both. The causes of cardiac arrest that there are the 6H and 5Ts are there is a hypoxia, hypotension, hypothermia, hypoglycemia, acidosis, or maybe there is a hypo or hyperkalemia. While in case of there is a cardiac tamponade, tension pneumothorax, thromboembolism for the pulmonary and coronary, or toxicity of the drugs or overdoses of the drugs. There are the phases of cardiopulmonary resuscitations. There are the three phases. Phase 1 is a basic life support in which there is a steps you have to take. There is a CAB is a circulation airway breathing, while in case of there is a phase 2 there is a advanced cardiac life support in which there is a CAB followed by a DEF. There is a drugs, ECG monitoring and fibrillation. For that you have to defibrillate the patient, use the defibrillations. And phase 3 is a prolonged life support in which there is a post resuscitation care. What do you mean by basic life support? It is the life support without the use of special equipment. It is called basic life support. While there is what is the advanced life support? It is the life support with the use of special equipment. Examples like airway, endotracheal tubes, or defibrillations. How can you diagnose the cardiac arrested patients? By the using of the triad of this loss of consciousness, loss of apical and central pulsations like carotid and femoral, and loss of respirations. For a loss of consciousness is early recognition. How can you early recognize the patient whether they are arrested? For that you have to check for the unresponsiveness of the patients. Check the victim for the response, shake the shoulder, ask are you alright or not. If the victim is unresponsive, if they are two rescuers or lone rescuers and then two rescuers. For lone rescuers, there you have to activate the emergency medical system, followed by return to the victim and then then give the CPR followed by defibrillation. When in case of the two rescuers, you begins with the CPR and activate the emergency medical system and give the defibrillations. Check for the breathing or no normal breathing and patient is gasping, whether you can feel the pulse. If there is a no pulse felt within the 10 seconds, you have to start the CPR. This is the simplified adult basic life support algorithm, which suggests that if the patient is unresponsive, if the patient is not breathing or no normal breathing, only gasping, you have to activate the emergency response team, and then you have to start the CPR. You have to get the defibrillator and check for the rhythm. Either rhythm is shockable or non-shockable. If the shockable, then give the shock and repeat the CPR every 2 minutes. And then give the CPR as a push hard and push fast methods. The CPR sequences. Initially, there is a CPR sequences was ABC. Now it's a recent guidelines changed from the ABC to CAB. And the first compression is there, second is airway, and third is the breathing. The techniques of chest compressions are there. We are going to discuss. The first, put the patient on firm surface. Then kneel next to the person's neck or shoulders. Then place your heel of one hand over the center of the person's chest between the nipples and place your other hand on the top of the first hand. Keep your elbow straight and position your body over the chest. Use your upper body weight, not just your arms. As you push straight down on compresses the chest at least 2 inches or approximately 5 centimeter, and push hard and push fast at the rate of 100 to 120 compressions per minute. Allow the chest to recoil, but do not leave the hand from the chest. The CPR, in that there is a chest compression, you must be performed at the rate of 100 to 120 per minute, and during the CPR the ratio of chest compression to the ventilation should as follows. For the single rescuer, at least 13:2 ratio for the compression versus ventilations. In the presence of 2 rescuers, chest compressions must not be interrupted for ventilations. Why we have to start from the ABC? We have to change from protocols from the ABC to the recent guideline says it is a CAB, because the human brain cannot survive more than 3 minutes with the lack of circulation. So the chest compression must be started immediately or as early as possible. The problems and complications of chest compressions are the rib fracture, fracture of the sternum, rib separation, pneumothorax, hemothorax, lung contusion, liver laceration, fat emboli or infection. The basic techniques for airway patency is there is a basic techniques. For the airway patency, you have to head tilt and chin lift methods, or this is the method in which there is a head tilt and chin lift, or maybe the jaw thrust in case of the cervical injuries. On all these things, you don't have to head tilt and chin lift method. You have to use this jaw thrust methods. While Heimlich maneuver, that the patient is conscious and the foreign body cannot be removed by the finger, then you have to give the abdominal thrust. While giving the abdominal thrust, there is air come out from the lungs, and that's why there is a foreign body come out from the oral cavities. While in case of the for infants, you have to give the blows on her back. I check for the normal breathing for 5 to 10 seconds, and if there is a no breathing, then you have to give the basic techniques for including the how to give the breathings. They are the mouth to mouth breathing. They are giving the mouth to nose breathing for infants and children, and mouth to mouth and mouth to nose breathing. Assessment and restoration of breathing and circulations. For how to assess the patient is having a restore their breathing and circulations by you can assess by there is a contraction check for the pupil is contraction of pupils, improve the color of the skin, there is a free movement of the chest wall, there is a swallowing attempts, strangling movements, and return of strong pulses and return of systemic blood pressures. When to terminate the basic life support? When the patient's pulse and respiration returns, then you have to stop the basic life support. When the emergency medical help arrives, then you have to stop the basic life support. And if the patient declared disease, then you have to stop the basic life support. And if there is an rescuer is exhausted and physically unable to do continue for the basic perform this basic life support, then this is the stops. When you stop the basic life support, when spontaneous breathing, when the patient's spontaneous breathing is come and trained personnel arrived and operator exhausted, physician assumes responsibilities and scenes becomes unsafe, then you have to stop for the basic life support. Now we will go for the advanced cardiac supports. The ACLS includes there is an circulation is re-empowered by the cardiac massage, and use of there is an advanced airway techniques, giving the defibrillations by manual defibrillators and using of drugs. The chest compression first. The chest compression is given by this method, in which there you have to see that the elbow should be straight and your upper body weight should be over the chest, and you have to push hard and push fast. there is a two mechanisms for explaining the restoration of circulation by external cardiac massage, in which there is a cardiac pump and thoracic pump. In the cardiac pump, when you apply, is the mechanism in which there is a blood pumping is assured by the compression of heart between the sternum and the spine, while between the compression the thoracic cage is expanding and the heart is filled with the blood. While in case of the thoracic pump at the cardiac massage, well, the blood circulation is restored due to the change in the intrathoracic pressure and the jugular and subclavian vein valve, while during the chest compression, the blood is directed from the pulmonary circulation to the systemic circulation, and the cardiac valve function as in the normal cardiac cycles. There are the advanced techniques for airway patency. There is a face mask we are using oropharyngeal airway, a nasopharyngeal airway, endotracheal tube for intubation, laryngeal mask airway, combi tube. It is in device. These are the devices we can use in the emergency airway management. We can also use the cricothyroidotomy in case of there is a polytrauma patients when we cannot do the intubation. So there we can use the cricothyroidotomy or tracheostomy, and this is the basic method in which there is a seal can be formed over the mouth by using the umbu and face mask. By giving this is the basic idea of the expired air contains 60% oxygen while you giving the mouth-to-mouth breathing. While there you giving the breathing from umbu bag, then at least that umbu bag contains the room air, so it is around 21% oxygen you give to patients. While the umbu bag plus oxygen is around 10 to 15 liter of oxygen you attach, then it is around 45% of oxygen you give to patients. While in case of the umbu with the reservoir bag, at least 85% of the oxygen you can give the patients. There is defibrillations for giving the therapeutic dose of electrical energy to the affected heart with the device called defibrillators. That is a basic math. This is the basic thing that how can you position the pedals for the giving the defibrillations. The one pedal is placed in the right infraclavicular region, while the other is placed in the left fifth and sixth intercostal space in the anterior axillary line. While in case of the anterior posterior side, the alternative the anterior posterior position may be used, in which there is a one pedal is placed in the left infrascapular region, while the other is placed in the left fifth or sixth intercostal space in the anterior axillary line. You can give the shock by biphasic or monophasic shock, whatever the first as a manufacturer recommend. Initially you have to start with the 120 to 200 joule, and then you have to gradually increase the and then on monophasic you have to give the 360 joule shock. In the cardiac arrest, the associated rhythms can be categorized in two groups. There are the shockable rhythms or non-shockable rhythms, and which are the rhythms which are shockable is a VT or ventricular tachycardia or ventricular fibrillations, while in case of what are the different other rhythms which are non-shockable, they are the asystole or pulseless electrical activity. There are some drugs used in the CPR. The primary drug is adrenaline. We can use is an 0.01 mg per kg IV every 4 minutes while the continuing CPRs. And now recent guideline says that is an where you give the adrenaline when in case of there is a non-shockable rhythm, you have to give as early as possible. The first you have to give the adrenaline, while in case of the shockable rhythm in like ventricular fibrillation or ventricular tachycardia, you give after the short shock. Amiodarone again 300 milligram or 5 mg per kg dose, and given in the shockable rhythm after the third shock. And also the lignocaine 1 to 1.5 mg per kg. And vasopressin is also the drug, but recent guideline says the vasopressin is removed from that guidelines. Magnesium you can use in the dose of 2 gram IV is a case of ventricular fibrillation or ventricular tachycardia which is not reversed with this amiodarone or shock, then you can use these things. And calcium again, it is a 10% of the 10 ml of the calcium chloride you can use in case of the pulseless electrical activity which is caused by the hyperkalemia, hypocalcemia, hypermagnesemia. While IV fluids you can use infused fluid rapidly if the hypovolemia you can suspect it, then use the normal saline or ringer solution. Dextrose is indicated only if there is an documented hypoglycemia is there. You can use the sodium bicarbonate 1 milliequilibrium per kg per dose, but in case of severe metabolic acidosis or if there is a life-threatening hyperkalemia, then an atropine is used in case of sinus bradycardia or AV block. Adult basic life support algorithm for healthcare providers, in which you have to verify the scene safety, you have to check for the responsiveness, shout for nearby help, activate the emergency response system via mobile and device, and get the automated electrical defibrillator and emergency equipments. Then you have to look for the no breathing or only gasping, and check for the pulse. if you are not able to feel the pulse for the 10 seconds, then you have to start the CPR. For that you have to first normal, if the patient is normal breathing and you can able to feel the pulse, then you have to monitor until the emergency responders arrives. While in case of there is a no normal breathing or pulse, you can able to feel the pulse, then you have to provide the rescue breathing, one breath every for 6 seconds or 10 breaths per minute, and you have to check for the pulse every 2 minutes. If there is you are not able to feel the pulse, then you have to start the CPR. If there is a no breathing and you are not able to feel the pulse, then you have to start the CPR immediately to perform a 30:2 ratios. In this, there is a 30 compressions and 2 breaths, and use the automated electrical defibrillator as soon as the possible. If automated electrical defibrillator arrives, then you have to check for the rhythm, whether the rhythm is shockable or whether the rhythm is not shockable. If the rhythm is shockable, then you have to give the one shock and resumes the CPR immediately, and continue until the advanced life support teams arrives. While in case of there is a non-shockable rhythm, you resume the CPR immediately and for 2 minutes, and until you have to continue the CPR until that the advanced life support providers take over. Then you have to start the CPR and give the oxygen and attach the monitor or defibrillators. And then you have to check for the rhythm, whether the rhythm is shockable or non-shockable. These are the some shockable rhythm like VF or VT or ventricular fibrillation or ventricular tachycardia. Then you have to first give the shock, and followed by there you are giving the CPR for 2 minutes. At that time you have to take the IV or intraosseous SS, and then again you have to check for the rhythm. If there is a shockable rhythm, then you have to continue the CPR, followed by you have to give the adrenaline every 3 to 5 minutes, and consider the advanced airway capnography. And then after that you have to again check for the rhythm, whether the rhythm is shockable or non-shockable. If the rhythm is again shockable, then you have to continue your CPR for 2 minutes and give the injection amiodarone or lignocaine. When in case of there is a non-shockable rhythms, as like asystole or pulseless electrical activity, you have to give adrenaline as early as possible, and if you followed by their CPR continue, and you have to take the intravenous or intraosseous SS, followed by there is a adrenaline given and every 3 to 5 minutes, and consider the advanced airway capnography. While there is a rhythm is still there is a shockable, then you have to give the shock, and again check for the same rhythm from the give adrenaline and give amiodarone. And while in case of there is a asystole or pulseless electrical activity, you give the adrenaline. This is the CPR quality, the push hard and push fast methods. In push hard, at least 2 inches or 5 centimeter, and push fast it is 100 to 120 per minute. Allow the complete chest recoil and minimize the interruption during the compressions. Avoid the excessive ventilations. Change the compressors every 2 minutes and or sooner if fatigue. And if no advanced airway, then there you have to give the CPR in the 30:2 ratios. Quantitative waveform capnography. EtCO2 is also important things. You have to reassess the CPR quality. If the EtCO2 is low, then give the shock rhythm, shock energy, or for defibrillation, in which there is you can use the biphasic or monophasic drugs which are used in during the CPR. They are the, I already told you, there is the adrenaline, amiodarone, or lignocaine. Now there is the adult immediate post cardiac arrest care. For that, if you are giving CPR and your CPR is successful and you have to return of spontaneous circulation, then you have to do these things. In this, there is the first you optimize the ventilation and oxygenation by maintaining the oxygen saturation more than 94%. Consider the advanced airway and wave for the capnography. Do not hyperventilate these patients. For treating of the hypotension, keep the systolic blood pressure at least more than 900 mm of Hg, in which you have to, how we are going to treat the hypotension by giving IV or intraosseous bolus fluids, or most probably you can use normal saline or ringer lactate. While you can use for treating the hypotension, you can use the adrenaline infusion, dopamine infusion, or norepinephrine infusions. And if after that you have to take 12 ECGs, and then if you are then you have to check for the following, check for the patient is follow verbal commands or not. If the patient is follow verbal command, then you have to check for the ST elevation MI or acute MI. And if there is a patient is having and then if a patient is developing this ST elevation MI or acute MI, then you have to go for coronary perfusions. But if the patient is not able to follow the verbal command, then you have to consider for induced hypothermia. For initial stabilization phase after the CPR is the resuscitation is going during the return of spontaneous circulation phase, in which there is a airway management is very important. You have to waveform the capnography or capnometry to confirm the monitor the endotracheal tube placements, manage the respiratory parameters for titrating the FiO2 and titrating the FiO2 for SpO2 to maintain around 90 to 98%, and manage the hemodynamic parameters by using the IV adrenaline, noradrenaline or dopamine. While after that, for continued management and additional emergent activities, in which this evolution should be done concurrently to show that the decision targeted temperature management, in which that if you are see that patient is not following verbal command, then you have directly go for there is a target temperature management, in which there is a target temperature management. In the emergent cardiac interventions is early evolution of 12 ECGs also, then the target temperature management, in which the patient is not following command, then you have to start the target temperature management as soon as the possible, begins at 30 to 36 degree for 24 to 72 hours by using the cooling devices. Then other critical care management, in which there is a continuously monitor the core temperatures, maintain the normoxia, normocapnia, euglycemia, provide the continuous electroencephalogram, and provide the lung protective ventilations. For now we'll see for the pediatric cardiac arrest algorithms, in which there is a start the CPR. If you can see these things, the patient is not responding, not following verbal command, then and you cannot able to feel the pulse, then start the CPR, followed by begin with the bag and mask ventilation or give the oxygen, and attach the monitor and defibrillation, and you have to check for the rhythm, whether the rhythm is shockable or non-shockable. Whether the rhythm is shockable like VT or VF, you have to give the shock and continue a CPR, and you have to take the IV or intraosseous access, and then you have to again check for the rhythm. If the rhythm is again shockable, you have to give the IV adrenaline, and then again you have to check for the rhythm. After giving the 2 minutes of CPR, you have to check for the rhythm. If the rhythm is again shockable, then you have to give the amiodarone or lignocaine. While in case of there is a asystole or pulseless electrical activity, I already told you there is adrenaline you must give as early as possible, and if you feel the patient is asystole pulseless activity, then you have to start the CPR for 2 minutes, and then you have to take the IV or intraosseous access and give the adrenaline, and again check for the rhythm, whether the rhythm is shockable or non-shockable. According to that, you have to treat the pediatric patient same. But for pediatric patient, we have changed these things. The chest compression is given for infants by these two methods. First is the two-finger method, in which you have to give the CPR by 2 fingers on the lower half of the sternum, while in case of second figure, he says suggests that by encircling the arm and giving the chest compression by thumbs. For CPR quality for pediatric patient, push hard and push fast phenomenon, in which there is a push hard around at least 1/3 of the anterior posterior diameter of the chest, and push fast at least 100 to 120 per minute, and allow the complete chest recoil, minimize the interruption during the compressions, and change the compressors every 2 minutes. And if no advanced airway, then a 15:2 compression ventilation ratio you have to give. And for pediatric patient, the shock energy for defibrillation is around first shock around 2 joule per kg, and second 4 joule per kg, and subsequently more than 4 joule per kg, maximum 10 joule per kg or adult doses. For drug therapy, for pediatric patient is same again, adrenaline, amiodarone and lignocaine. And for advanced airway, you have to use endotracheal intubation or for supraglottic airway, and waveform capnography or capnometry to confirm the monitor the endotracheal tube placements. For patients, that pediatric patient who develop bradycardia with a pulse algorithm, then you have to give the if the patient is having a bradycardia, then you have to give the adrenaline first. For pediatric patient is a 0.01 mg per kg, and atropine you can use as also as a 0.02 mg per kg, and treat out the possible causes for bradycardia in pediatric patient is a hypothermia, hypoxia, and some drug induced bradycardia. While in the pediatric tachycardia with the pulse algorithm, according to in which that you have to give the dose of synchronized cardioversion, in which you have to begin with the 0.5 to 1 joule per kg. If not effective, then increases to 2 joule per kg. Sedate if needed, but don't delay the cardioversion. And drug therapy you can use for that pediatric tachycardia patients in the adenosine IV. First dose is around 0.1 mg per kg, rapid bolus 6 mg, and second dose is a 0.2 mg per kg, rapid bolus. The highlights of the 2020 American Heart Association, the guidelines for the CPR and emergency cardiac care, in which there is a these are the 7 parameters you have to see. There is a early initiation of CPR by lay rescuers, because there is a no any harm to the patient when you have to start the CPR as early as possible, and then you have to give the administration, then you have to administer the adrenaline as early as possible. In case of the, you have to check for the rhythm, whether the rhythm is non-shockable, then you have to give the adrenaline as early as possible, while in case of the rhythm is shockable, then administer the adrenaline after the initial defibrillation attempts have failed. Then there is a third thing is increase the willingness of bystanders to perform the CPR. It can be done by making this CPR training, CPR mass training, or CPR awareness program. While there is a fourth thing is a care and support during the recovery, in which there is an post cardiac arrest care. You have to give these things. There is a multimodal rehabilitation assessment and treatment for physical, neurological, cardiopulmonary and cognitive impairment before the discharge from the hospitals, and they also recommend the structural assessment for anxiety, depression, post-traumatic stress and fatigue of the cardiac arrest survivors and their caregivers. The post-cardiac arrest care and neuroprognostications. In this, there is a neuroprognostication should be performed no sooner than 72 hours after return to the normothermia. Then debriefing for the rescuers, and they are debriefing the rescuers as well as the emergency medical service providers, and as well as the hospital-based healthcare workers after the cardiac arrest event may be beneficial. And then you have to register this all data and data registries to improve the system performance by using this CARES registry, in which there is a cardiac arrest registry to enhance the survival registry. Thank you.